And go.
Okay. So, so first question to ask is, why do we ever do anything in terms of pancreatic intervention? It's actually a straightforward answer to you guys. Like, why would you ever do an ERCP for any sort of pancreatic duct intervention?
You have some sort of blockage.
Yeah, some blockage.
Pancreatitis is deadly.
It's simpler than that.
Really?
So it's really just pain.
Oh.
Okay, so pancreatitis is deadly, very rarely does, and that may be a tiny bit of an exception, but rarely does pancreatitis really result with any sort of pancreatic duct stenting, acute pancreatitis. Okay, and blockage is the reason you do the intervention, but it's very important to recognize that while blockage is the technical reason, it is really pain that you want to treat. So there's a lot of people who have pancreatic duct blockages and are completely asymptomatic. And there is no, unlike in bile duct blockage, where you can be asymptomatic and it can mean something significant, for the most part, asymptomatic pancreatic duct blockage is not necessarily an intervention reason, okay? It is sort of a simplified theory. We don't have a whole lot of better ones. That when there is a blockage in the pancreatic duct and there's upstream dilation of the pancreas above that blockage and the inability to secrete pancreatic juices causes pain. Okay? One of the reasons we're conducting this study, and we'll come to it in a second, is really to try to understand, does the blockage actually cause the pain? Or is the pain and the blockage sort of true and unrelated things? If you think about the patients you've seen with pancreatitis and blockage, many of them, it's not just that there's a focal blockage and everything else is perfectly fine, right? There's a lot of inflammation around the pancreas. A lot of these patients have chronic pain, etc., etc. The question is, does just relieving the blockage really relieve their pain? Is this the source of their pain? Okay, so how do we, so what are the ways to sort of relieve the blockage? Well, there's really only three components to this, okay? So if you imagine that there's a blockage here, okay, and there's upstream dilation, okay, the dominant way to resolve this blockage is to first place a stent, break the scar or the obstruction area. If there is a stone, those are the cases we do as well procedure. You guys know why it's like when you see bile duct stones, for the majority of the cases, we go in there, we sweep out the bile duct stone comes out. Occasionally you have to break them up because it's too big. Why do we do ESWAL so much for pancreatic duct stones?
Is it because the pancreas is very fragile?
So it is fragile and you want to break it up more, and pulling out a centimeter large stone is sometimes hard. But this actually demonstrates the answer. So unlike bile duct stones, which form in the bile duct and 99% of the time are just kind of bouncing in there, pancreatic duct stones are calcifications that form in the pancreas. So you don't, it's almost like a rock that sort of goes into the duct but comes from the parenchyma. So you can't just pull it out because part of it is kind of built into the pancreas itself. So by breaking it up, the thought is that you're gonna break it up enough so that the intraductal components can be removed, okay? So let's do the 5-minute sort of how do we do an intervention and what are things to watch for. We'll just take one
I got a
step.
tone that was too skinny. I didn't put any sense out. Do you want to do that?
It's okay. So the most important part of this from a sort of technical standpoint is to recognize what damage you can do, okay? And some of the damage is on our sort of manipulation part, and a lot of that, okay, perfect. And a lot of that has to do with the cannulation. So that's your highest risk. What is roughly the risk you think of causing pancreatitis from just the intervention? Rough percentage. What percent of people will get acute pancreatitis?
10.
5, 10, keep going. So somewhere between 10 and 20, okay? So these are high-risk interventions, okay? On the second attempt, it's closer to 5, okay? When you've done the sphincterotomy, but it's a high-risk intervention. The next damage you can do is that when there's an obstruction, okay, unlike the bile duct, which is a tube, there's many, many side branches, okay? So the wire will go out wherever it wishes, especially in front of an obstruction, and you've perforated the pancreas, okay? For the most part, it's okay. Like a little wire goes out, you're okay. But you'll see us sort of getting very sure that the wire does the sort of typical path and not some funky path. Because once you've started to put like a tome over the wire and you've really sort of jammed it through the parenchyma, there's a pretty decent chance that you're giving the patient a pseudocyst or some sort of a pancreatic damage pancreatitis in that area. And the last part, and from a sort of technical standpoint, I'm gonna just open one wire. This is probably the most important sort of part of this, which is so this is the other place where you can perforate the pancreas, right? So if the wire begins to go out, further out on the left side, okay, you're gonna go through the tail of the pancreas. So this is one of the interventions when we will very carefully and attentively ask you to keep this wire very precisely at the length of the pancreatic duct that we know from injection is the duct and not the spleen or whatever. Okay, so when you push a stent over this is truly the one scenario where you want to be really controlled, and this to some extent needs to stay about exactly where it is while you're pushing the stent and not allow the wire to do this. And of course, and that always is the case, not allow the wire to come back too much further. Okay, so that is actually sort of in a nutshell. Okay, the rest of the stuff, what size stent you use, how many stents you use, is really driven by the patient's symptoms, how well the obstruction has broken up. But on your initial procedure, okay, you want to get through a sphincterotomy relatively smoothly without a ton of damage. You want to be sure that you've crossed the wire across the obstruction and that you're only in the main duct and not in the side branches. And when you place a stent, you want to be sure that the stent is across the obstruction where the stone or the narrowing was, okay? Now, the last comment about this is that you see a lot of pancreatic cancer patients here. I don't think you've ever seen pancreatic stents placed in pancreatic cancer patients for pain, okay? And that's always an interesting paradigm to think about. For many reasons, cancer pain does not respond to ductal obstruction relief, okay? So the only time you will see intentional pancreatic duct work is going to be in chronic pancreatitis, basically, okay? And only if they have pain, okay? So then this is a decent segue to what we're doing with Rachel and the anesthesiology group. So one of the sort of hard paradigms in the management of chronic pancreatitis has always been that you see these patients who have chronic pancreatitis. A lot of them have a history of alcohol abuse. Not all, but that certainly is the most common reason. They'll develop a stone. They'll have some chronic pain, okay, and then we'll recommend that they get a stent placed, okay. And if you've seen some of these patients, you know that many of them have had these interventions now like 10 times, okay? There are some names that you probably recognize from coming so often for this, okay? And one of the reasons for that is that sometimes a technical success, a perfect, relief of the obstruction doesn't end up in a sort of clinical success and doesn't end up with the patient having pain relief, okay? The study that we're doing is a study that tries to understand how the patients perceive pain, okay? and use that as a predictor of whether the pain is predominantly driven by what's happening here, or is it what is sort of a paradigm in chronic pain perception is sort of an altered pain perception that probably at some level was caused by this change or inflammation, but is no longer sort of a local pain perception, okay? So there's two components to this. We do and I'm gonna let you discuss the QST and the EEG part. So there's two components that we're assessing, well, three actually. One is questionnaires. How do you perceive pain? Okay, so the study asks a lot of questions to try to understand how you perceive it. The second part of it is the study asks directly how the patients perceive pain. So Rachel, maybe you want to discuss how the QST is done. It a little bit sounds like a bit of sort of torture. It's a very well-validated way of assessing how the patients perceive pain. And then the third component, I'll let you go through QST, and the third component is EEG. So actually measuring how pain is perceived when the patient is stimulated. Okay?
Yeah, so there's, thank you. That was really interesting. I actually
Rachel, 5 minutes.
Okay, okay. So I'll take like 2 minutes.
Okay.
Basically, we do something called the QST procedure, and there are like 3 components to that. So there's a pinprick, which looks like a ballpoint
She's
pen,
off today.
like it's retractable and doesn't actually touch your skin. And then
Is that
we
me?
have the pressure pain tolerance, where we use something called an alcometer to press against the patient's essentially different parts of their body, soft tissue, not on the bone definitely. And so we see what their pain tolerances are, like when they first detect pain and when they find their maximum tolerance. And by the way, this is all done with the EEG on their head, so we're measuring kind of like how are they responding to pain, even though we're not like inducing that much pain. And then the last part, which is the worst part, is it's essentially an ice bucket challenge, where we ask patients to stick their hands in 4 degrees of water bath and ask them to rate their pain for 2 minutes every 10 seconds. And so these are all different tests that we hope maybe induce different like pain signals in someone's brain or different receptors being tested. But that's pretty much it. Yeah.
So after this discussion, we're going to ask each and every one of you to do this pain stimulation. And we will not do that. All right. So if we have 1 more minute, any questions about?
Can you go over really quick, when would you choose this particular stent? This is hey guys, this stent that Dr. Gund is holding is kind of an obscure one.
So it is obscure, but so every stent that we use has a hole at the end and a hole at the bottom, right? So all our biliary stents, Siemens stents, whatever, okay? This is the only stent that's on the market that has side holes, okay? And it's a really nice stent developed for pancreatic duct drainage with the idea that if you have these side branches, and it's a tight duct, you want to have the side holes to allow the side branches to drain. Okay? At the end, I think it helps, it makes a difference, but there are some sort of logistical reasons that this also ends up being a nice stent. It's a little bit softer than some of our other pancreatic stents, and it does not have a flange on either end, so you can cut it to whatever size you want. Okay, so and that's a nice thing. Like you can basically just measure it out on your fluoro, then take a tape measure to it, and then cut it.
And that's the whole delivery system?
And that's the whole delivery system. It's a simpler kind of variation of the Oasis delivery system to
There's a lock and unlock.
There is no lock and unlock on any of these stents. So these are all of the pancreatic stents are over a introducer catheter. And again, you have to be super careful that basically the critical part of this procedure is to make sure that your wire remains in a stable, unchanged position. You don't poke out, you don't pull back, okay? In the bile duct, unless you're tickling the scapula up in the shoulder, too much wire will not make a huge difference, okay? In the pancreas, it can make a huge difference, okay? If you poke it multiple times, especially in the tail, you'll get somebody develop a pseudocyst. We've all had this happen.
And that's called the Jolin stent, and it
This
lives
is a
up on the
Jolin
top shelf near the Spy products.
Okay, the other stents, so really, it's very simple paradigms. Hobbs stents are soft stents, essentially developed for prophylaxis. Okay, they're there so that you don't feel them. The typical pancreatic stent, Siemens stents, are a little bit harder. You typically use it and it was developed to cause to be more stiff and to break strictures. Okay, so you'll see us ask for a Hobbs stent. I think hello. Ask for a Hobbs stent for the most part when you're dealing with like a double wire cannulation and you just want to put in a stent to protect the pancreas. Whereas you'll see us ask for the Siemens, right? Siemens pancreatic stents, which are typically therapeutic stents. Okay, so you're putting them in to effectively break and bypass the stricture.
Very good.
Time?
Yes,
All
good.
right.
Thanks.